Hello everybody. Sorry we're getting started a couple of minutes late today. Just had a couple of last minute things to pull together here, but today is Friday, which means it is time for COPD Navigator Live, our weekly look inside the world of COPD. My name is Mike Hess. I'm a respiratory therapist and COPD educator. I also run the group COPD Navigator on Facebook, so please come join us at the addresses below. Where we do this talk every Friday. We start off with a little bit of news update from the world of COPD, then we get into our topic of the day, which today is a disease called bronchiectasis, very tightly associated with COPD and yet relatively unknown, like so many other aspects of COPD. Then toward the end of the show, for about a half hour or so, we can take your questions live. So if you have any questions firing up here, percolating in your brain, whether they have to do with bronchiectasis or any other aspect of COPD care, please put them in the comment section, either below or next to, depending on where exactly your screen is oriented and all that kind of fun stuff. Before we get started, I do want to send some good wishes, thoughts, prayers, whatever your particular motivation is, to a good friend of Navigator by the name of Janice. Right before the show started here, Janice mentioned that one of her very good friends had a heart attack, and she was not going to be able to catch the show today, but I would like everybody just take a minute and send some positive energy out in the universe. Keep Janice, her friend, and all of their family members in your thoughts as we get through the episode today and, of course, into the weekend. So with that in mind, we're going to start. It's a fairly light news week today, or this week in the world of COPD. Probably the biggest news out there is a study that was just published in Journal of the American College of Chest Physicians, which is known as CHEST, talking about the long-term effects of... get that to work right. Long-term effects of inhaled corticosteroids in the setting of COPD, specifically as it relates to the risk of bone fractures. It's long been known that a variety of steroids, particularly those that we take orally or intravenously, are linked to decreases in bone health and that sort of thing. But the question has been for a very long time, do inhaled corticosteroids work the same way? And so this study aimed to try to shed some light on that and found that there was a slight, a modest, as the authors described it, increase in hip and upper extremity fractures for those people who are on relatively high doses of steroids. These are your maximal doses of inhalers for 4 or more years. The study did not prove a true cause and effect relationship. There was, like I said, an association, and it was still relatively mild. I believe the value was there was approximately 1 extra fracture for about every 400 people who were on these steroids for a very long time. The overall rate is still very low. Roughly about 15 people for every 1,000 on these high-dose steroids for a long period of time have a fracture. But it's not zero. The risk is not zero. And this is kind of more evidence to fuel the fire of trying to move away from inhaled corticosteroids and minimize that risk to whatever degree we can when we're talking about the use of steroids in the setting of COPD. Again, especially ever since the last Global Initiative for Obstructive Lung Disease recommendations came out, we've been trying to move away from the use of inhaled corticosteroids, particularly as a frontline therapy. We know that they increase the risk of pneumonia slightly. We know that they have other negative side effects, particularly for those people who are on them for a relatively long time, as many people with COPD are. And so we're trying to move away from that. We're trying to get a better grip on who actually benefits from the use of inhaled corticosteroids so we can maximize the benefit while minimizing the risk. And so this just adds some fuel to that fire as well. The other big news this week, I guess, is not necessarily a nationwide thing, but I was very excited to. Yesterday, we received here at the clinic our very first Harmonicas for Health starter kit. We're going to be starting a program here in partnership with one of our local hospital groups. For those of you who aren't familiar with the program, Harmonicas for Health is a program that was designed by the COPD Foundation in association with the American Country Music Association for Country Music. I sadly can't quite remember what their what the ACM stands for, but one of the big country music groups down in Nashville, to kind of create a program to go along with pulmonary rehab, but also to be kind of a social environment where people can get together, learn how to play the harmonica, and learn some breathing techniques and get out of the house and socialize with some other people walking the COPD path and all that kind of thing. We're very excited. It's a program that is growing across the country, and we're very excited to bring it here to southwestern Michigan. We're hoping to get that started later on this spring. Like I said, I just got the stuff today or this morning, and so I'm really looking forward to taking a look at it and partnering with our local hospital group to get everybody on board with that. So that is a brief look at the latest news today in the world of COPD. So we're going to get on to our main topic of today, which is a disease called bronchiectasis. And bronchiectasis is one of those things that is widely misunderstood, in my opinion. I'll be frank, I didn't even really know a whole lot about it until a couple of years ago when I started going. I went to one of our national respiratory conferences. Saw a couple of places in the exhibit hall, got to learn a little bit more about that, started to learn a little bit more in some of the sessions, and then once we started our clinic here in Kalamazoo, actually was visited by a couple of people from who are involved in some of the devices that we're going to take a look at later on today. Been able to work a little bit more closely and learn a little bit more about bronchiectasis, and I have found that much like alpha-1 antitrypsin deficiency and some other phenotypes in COPD. It's one of those things that it kind of gets lumped in with COPD, but it is distinctly different, and there are some very particular treatment options that are only available if you are able to get that diagnosis. So I wanted to try to shed some light on that, if you will, so that because a lot of people with COPD have bronchiectasis and probably don't even know it. So, what exactly is bronchiectasis? Well, put simply, bronchiectasis is a change in your airways where they can kind of become widened. They become a little floppy or flabby, and they can kind of even in some circumstances kind of pooch out a little bit. This is a graphic I took. I think this was from the British Lung Foundation, this is a legit graphic. And you can kind of see with normal, I can't really point to it very well, I guess, with the way the overlay works, but with normal airways, you can kind of see they look like the branches of a tree. As you start with near your trachea, they're very wide. As you get farther out into the lungs, they get narrower and narrower. They have kind of a tapering off. In what is supposedly the most common and least severe supposedly form of bronchiectasis, we see that because the airways kind of lose some of that tone, or they lose that structure, they kind of turn into cylinders. They lose that taper. They become more of a cylinder shape, and makes it more difficult to move mucus through there, which kind of becomes this kind of vicious cycle where they get flabbier and then more mucus accumulates and can get infected, which damages the airways even more, which makes it easier for mucus to build up, and so on and so forth. You can see in some of the more severe cases, the varicose type, I'm going to learn how to do this sooner or later. Varicose type and the cystic type, you actually have even more pooching out, so to speak, and you have buildups of lung damage. You have buildups of loss of tissue integrity, and you have a lot of mucus. That's kind of the hallmark of bronchiectasis. In many respects, very similar to diseases like cystic fibrosis, and often confused, or sometimes bronchiectasis can actually be a part of cystic fibrosis, but in those cases it's sometimes looked at a little bit less of a separate disease and just as part of the cystic fibrosis treatment plan. Unfortunately, we're not to that point yet in COPD, but that's kind of what we're working on, and trying to use some of these educational opportunities to move the diagnosis and treatment of bronchiectasis as part of the standard plan for COPD care. As far as what causes bronchiectasis, there's actually quite a bit of stuff. I mentioned cystic fibrosis is probably the main causative vector agent, whatever we want to call it, for bronchiectasis. But of course, that's generally diagnosed when you're a kid. because of some other issues that go on with cystic fibrosis. So when you are an adult and diagnosed with bronchiectasis, it can be caused by several other things. Perhaps most notably or insidiously, it's caused by some autoimmune disorders. Particularly people with Crohn's disease tend to have higher prevalence of bronchiectasis, rheumatoid arthritis, that sort of thing. It's also caused a lot by infections. We see it a lot in people who have some immunocompromise. They might have a low level of the immunoglobulins. We see it in COPD, obviously. People with chronic bronchitis are easily colonized by a lot of bacteria and kind of have an ongoing infection. And that infection serves to weaken those airways, the airway structures, and work to kind of collapse a lot of that stuff. COPD, and I was also just reading an article posted by one of our bronchiectasis experts that we have in the group, works for one of the companies that makes one of the vest therapies that we're going to talk about in a little bit. I believe he was the one that posted it. They've been noticing a lot of bronchiectasis in the severe asthma population, which kind of makes sense. Mucus is, of course, inflammation and mucus secretion are hallmarks of asthma, and severe untreated asthma in particular is very closely tied with the development of COPD later in life. So we see pretty much any disease that's going to cause this buildup of mucus kind of puts you at risk to go down this vicious cycle and get you into the risk of bronchiectasis. So how do you know if you have bronchiectasis? Well, it's interesting. I looked up, as I like to do my prep work for these things, I looked up a lot of the symptoms for COPD or for bronchiectasis. And they're probably going to seem very familiar to a lot of people. Some of the main ones are coughing up a lot of mucus, particularly if it's yellow, green, thick, tenacious kind of stuff, sticky. Shortness of breath, especially on exertion, a lot of fatigue, some wheezing here and there. And so that's why it's very easy to confuse bronchiectasis with COPD, or kind of disregard the likelihood or the possibility of bronchiectasis when you have COPD, because in medicine we are usually taught to, what they say, when you hear hoofbeats, look for horses and not zebras. Well, when you hear hoofbeats like wheezing and shortness of breath and things like that, you immediately think of chronic bronchitis and you immediately think of COPD. Unfortunately, we should be moving away from that, and I think we are a little bit trying to get more into personalized medicine and trying to look at the underlying causes of of some of these issues, and how do we treat that stuff rather than just giving it a label and throwing some meds at it. And that's where we come into some of the more advanced parts of diagnosing bronchiectasis. And probably the biggest, most important thing is to get yourself a CT scan, usually a high-resolution CT scan, because you can actually see the difference between chronic bronchitis and bronchiectasis pretty well on one of these CTs. We'll bring up here, we'll look at this. This is a CT scan, looking kind of from the top down and from the lungs. Kind of a cross section of the lungs from looking at it from probably about right here or so. And you can see on this CT scan where that arrow is pointing, you will see kind of a taper, hopefully, depending on how big your screen is, I suppose. You can kind of see where the airway tapers down a little bit. It starts very wide as it's close to the middle of the body, which is this side of the image. As it goes farther out here, it does kind of taper down. We can compare that to this image, where you can see in this side, this image, you can see where, if you look at the arrow, you can see where the airway is more of like a tube rather than that branch of the airway. This is what we call a cylinder sign, depending on the angle of the bronchus. Sometimes we can look at it from a face-on view instead of the top-down, and we'll see what we call a signet ring, which is where we see just a very broad part of the bronchus, and then we have a little bit of a blood vessel on top of it that looks like basically a ring with a big jewel on top of it. We call that the signet ring sign, and that's kind of another one of the hallmark indicators for bronchiectasis. We also see this concept of what we call the string of pearls sign, which is more in the The varicose type of bronchiectasis, a little bit more severe, where you have some, instead of just the widening of the airways, you actually have kind of the varicosities, I guess, like varicose veins almost, the lumpy, distorted kind of thing, and you can see that in this X-ray or in this CT scan, where you have little balls, the string of pearls, so to speak, as the airways kind of get distorted and get filled with mucus like that. And then even when we get a little bit more severe, we can look at this image here. This is again a top-down view where we look at a lot of the drops on. Sooner or later, I'm going to figure it out. This side of the image right here, we see a lot of balls, hoops kind of things. We see a lot of those rings. We see a lot of those widened airways. This is kind of more of the more severe, kind of the cystic bronchiectasis, where we have a lot of that widening, a lot of that buildup. And then finally, we have another face-on view here. And this is a pretty severe, this was according to Radiopedia. This was an image of cystic and varicose bronchiectasis with some of the cylindrical stuff mixed in there, of course. This is pretty widespread. A lot of times we can see it in certain specific parts of the lung, but sometimes we do see it very widespread, as in this case. This is obviously some bad news for this particular patient. So we really need to get the way these symptoms usually work is we see symptoms like coughing and all that stuff, and then you might go to get a chest x-ray because you're worried, you and your provider maybe are worried about chronic bronchitis or COPD or an infection or what have you, and you get a chest x-ray. Sometimes these things can show up on chest x-ray. Usually they're a little bit too subtle for that, and you actually do need to go to the CT scan. So hopefully you get that chest x-ray. Things still don't seem to be improving. You're on your antibiotics, you're on all this other stuff, you're trying to clear out all the mucus, all the secretions, all that stuff. Things still aren't getting better, and so then you say, well, maybe I need a CT scan. So you get scheduled for a CT scan, and then you get some of those results like we saw in that radiography, and then you can get kind of a definitive diagnosis. As far as how to what we should be looking for, there was a recent study that found in the United States approximately 139 of 100,000 people should be diagnosed with bronchiectasis. That's our estimated prevalence. Previously, our estimate was about 52 per 100,000, so we're seeing obviously that there is a large degree of misdiagnosis, underdiagnosis, hidden diagnosis, whatever label we want to put on it. It's obviously a much bigger problem than we had suspected, and we should be a little bit more aggressive in trying to find these cases. Especially as you look at in the older population, they found that once you hit about 75 years old, the rate actually skyrockets up to about 812 per 100,000 people, which still is arguably not that much. It's still considered a rare disease, but it's not rare if you have it. It's pretty much a fact of your life, and so we should be giving you the therapy that you need and that you're entitled to. What this all comes down to is about 500,000 people walking around in the United States with bronchiectasis, and again, like we said at the top of the program here, a lot of those people might not even be aware that they have it because they've never gone through that process of having the chest x-ray and then the CT scan and all the verification there and so forth. So once you actually do have the diagnosis, then what's the option here? Well, the first thing we need to do is look at what is the underlying cause of the symptom. Again, we looked at things like cystic fibrosis, but if you have that, again, usually you're tagged with that when you're a child. So we should do some other testing to figure out if there are any causes. Of course, first and foremost, when anybody pops up with a COPD diagnosis, especially with any kind of evidence of lung damage rather than including some of the coughing and things like that, we want to do that alpha-1 antitrypsin deficiency test. Of course, alpha-1 is probably the most underdiagnosed form of COPD, and that's the one that we can actually kind of do something about, where we can supplement that alpha-1 protein enzyme and make sure that we're slowing the progression of the disease to the best of our ability. Of course, once you start having some of that breakdown inside of your lungs, that can lead to the kind of hallmark pooching out and all that stuff of the airways, that loss of airway tension and all that sort of thing. So we want to make sure we're doing that alpha-1 test. We also want to take a look at your immune system status. We see one of the biggest things we want to test for is immunoglobulin assays, because we do want to make sure that your immune system is able to fight off a lot of that stuff. Because if you are having immune issues, then we can treat that and we can start fighting off the infection and again prevent some more damage from getting done. This is again one of those things where we can't necessarily do a lot of repair work. We can't necessarily fix the airways once we get damaged, but this is where we can break that cycle. Remember, I was saying that we have that cycle of lower airway quality leads to more mucus, leads to more infection, leads to lower airway quality, and we go that circle. If we can do a better job at clearing a lot of that stuff out, preventing that infection from setting in, then we can definitely break that cycle, or we can usually break that cycle and prevent additional damage from getting done and the disease from getting worse. Another thing is Aspergillus infection. We want to test for that because that is kind of a chronic infection that is another one of those zebras out there where we don't often think of, but can lead directly to aspergillosis and then into bronchiectasis and a lot of those breakdowns in that area. And as we were talking about last week, we do want to check your vitamin D level. Vitamin D is another one of those things, much like with COPD exacerbations, where lower levels have been associated with more bronchiectasis flares and with increasing symptom severity. So we want to make sure that again, we don't necessarily want to load you down with alpha or with vitamin D. We don't want to throw mega doses at you or anything like that. But we want to make sure that your levels are appropriate for your dietary recommendations. We want to make sure that you're certainly not low. And of course, again, in the wintertime, even though we've had a bit of a warm snap here in southwestern Michigan the last few days, we are still in the depths of winter, and we still haven't seen a lot of the sunlight. And that's where a lot of our vitamin D comes from. So it's very easy for those levels to drop, and whether they are a symptom of or associated with more severe bronchiectasis is a little bit unclear, but either way, we want to keep those levels up. We also see a lot of sleep disturbances in bronchiectasis, as you might expect. If you're waking up or if you're coughing every 15 minutes or so, then that's going to wake you up at night too. So we want to make sure that we don't overlook sleep health and sleep medicine as part of an effective treatment plan, which leads us into treatment of bronchiectasis. Again, a lot of this stuff is going to be very similar to bronchitis. The biggest difference here is with bronchitis, it's more of a true inflammation of the airways, where we can, to a certain degree, we can manage that a little bit better. That's where we throw some of those steroids in there, hopefully not fracturing any bones along the way. But we can bring down a lot of that stuff, and we can maybe have a little bit easier job with clearing out some of those secretions. Once we get into some of the structural damage of bronchiectasis, we need to be a little bit more aggressive. So we certainly start with a lot of the traditional COPD therapy plans, pulmonary rehab, the bronchodilators, the mucolytics, and a lot of that kind of stuff. But this is one of those places where mechanical interventions, so to speak, are a lot more important. And of course, there was recently a change in, I believe it was the European Respiratory Society, actually put as one of their frontline things, rather than medications, we want to start being more aggressive with chest wall oscillation and chest physiotherapy, which comes in a couple of different forms. First and foremost, the least invasive versions are our old friends, the oscillatory positive expiratory pressure devices. These are things, two that I have here in my office are the Acapella, which has been out for a little while now, sometimes called the pickle for probably fairly obvious reasons. And then more recently on the market has been the Aerobica. Again, I should point out that I am not remunerated or sponsored or anything by any of these companies. Anything I put out there is representative of the device, not necessarily an endorsement. That's for all you lawyers out there. But these devices help break up some of that mucus by first giving you a little bit of back pressure that opens up the airways a little bit more. And then I use this one because it's a little bit easier to show. We do get a lot of vibration in here as you blow through the device. Makes this vein go back and forth, which sends up a lot of vibrations back up into your lungs, and makes actually kind of a pleasant, pleasing kind of rhythmic sound. And you can see, even for somebody with relatively healthy lungs, can be effective in inducing a cough and then helping loosen up a lot of that stuff that happens in there. Of course, these devices, again, are fairly non-invasive. They're easy to use. You can take them with you. You can do them on the couch while you're watching TV. You can do them in the car, preferably not while you're driving. But you can kind of do them wherever you are, wherever you don't feel bad making a little bit of noise. You can do them in conjunction with nebulizer treatments. They're very flexible, very portable, very effective devices. However, sometimes you do need a little bit more. Again, we're talking about very thick, tenacious mucus that is getting into all these little nooks and crannies inside the lungs, and sometimes you literally need to beat it out. Traditionally speaking, we've done what's called chest physiotherapy. The most simple way is we're all taught in respiratory school to actually use our hands. We cup our hands like this to develop a little bit of pressure, and we beat on people's chests and backs and all that stuff. We bend them into different positions to help some of the stuff drain out. In theory, we can knock a lot of that stuff loose. In practice, it's, of course, not quite that easy. There's a lot of inconsistency. Even the most biggest strong like bull kind of therapists get tired after a while. Family members get tired after a while. And so we've developed a lot of adjuncts to go along with that. We have a lot of manual percussors and vibration devices and that sort of thing that, of course, they don't really get tired. They plug into the wall, and as long as you have juice, then you have percussion or vibration. They, again, work fairly well. They have some pros and cons. They're not the most effective device. They are very reliant on a lot of positioning. They're reliant on making sure positioning both in terms of where you're putting the device and then allowing the person to drain a little bit more. They work, again, okay. And so that led us to probably the most effective one. I actually happen to have the manual for this particular device. There are a couple of them on the market. This is called the Encourage Vest by a company called Respirotech. There's another vest out there called the Aflo Vest. They work similarly. I don't really necessarily, I think Brad might be on today, but I don't necessarily want to get into the pros and cons of each particular device, because there's going to, depending on who you ask, of course, there is going to be a little bit of that rivalry and figure out which one is which. And I don't want to get into any endorsement trouble. But be that as it may, both vests work relatively similarly. You actually strap the device on. You can see, hold up the picture again here. You can see that this is it comes in a vest. The vest is actually filled with air pockets or air passages connected to these tubes, which go into a compressor type device, which does a lot. It's kind of like this vibration on steroids, so to speak. It is very powerful. It is very rhythmic. These vests can work in programmable ways where they can kind of work down here and then work up a little bit and kind of spread, help move that mucus, help your usual, we'll call it the mucociliary ladder, to help clear out a lot of that stuff, for you to cough it out a little bit more easily and for you to break up a lot of that stuff. There are pros and cons. Of course, a lot of the devices, I believe the Respirotech device, I believe, prides itself on they call active exhalation, where it actually, when you put the vest on, it does kind of compress your chest and can make it a little bit harder to breathe, but the device is able to sense when you're exhaling and gives you a little bit less pressure so that you can exhale against that a little bit easier. Both devices, very fine devices, of course, and work very well. If I was somebody with bronchiectasis, I would definitely go with vest therapy, especially relatively early on, to try to make sure that we're clearing out as much of that stuff as we possibly can, and to make sure we're slowing progression down a little bit. Of course, these devices are fairly expensive, as you might expect. It's a big chunk of medical equipment to be going by, but the good news is, particularly with Medicare, if you have that diagnosis of bronchiectasis, these are covered devices. Unfortunately, we don't see them covered very much for standard COPD, which is why it's critical that we make sure we're getting everybody we possibly can tagged with that bronchiectasis diagnosis, because that opens up a whole new world of therapy options, reimbursement options, and making sure we're getting you the therapy that you need. In addition to some of these things, we can do antibiotics. That's kind of an up-and-coming thing in the world of COPD, where we're kind of doing this chronic antibiotic therapy, where we're trying to keep the infection down with those medications. There is, of course, some risk of antibiotic resistance and those kind of complications. However, again, this is an up-and-coming thing. We're trying to figure out exactly what population this is going to work well in. My gut tells me that it's going to work very well in people who tend to be on the chronic bronchitis side / bronchiectasis side, because we do definitely want to keep those infections to a minimum. And as kind of the ultimate resort here, the ultimate last resort, we do sometimes see surgical resection of lungs. This is particularly in those cases that are relatively confined to one portion of the lung or another. Those widespread cases, like we saw some of the radiology earlier, probably not going to be as effective there. But if you do have a relatively contained case of bronchiectasis, where you can kind of cut out the diseased area and prevent that from getting worse and prevent that area of infection from setting in, that is a possibility. So we do have a lot of options, ranging from very minimal to less invasive or non-invasive, to some of the big guns here, the vests out there, the vibration devices. They all work very well to, depending on the severity of your case, they do work to clear out a lot of that stuff and make sure that things are moving the way they should. So, we do see again that bronchiectasis is relatively underdiagnosed. It's often confused with more traditional bronchitis. We can see it, we can make a definitive difference between the two using a high-resolution CT scan. So if you ever have any concern that you're coughing up a lot of mucus, it doesn't seem to be getting any better, and you haven't had a chest CT or anything like that, it's definitely something you're going to want to discuss with your provider, whether it's a pulmonologist or in primary care. Discuss with them the possibility of bronchiectasis, so that you can at least get an answer one way or the other. And if you do end up getting diagnosed with bronchiectasis, you can move ahead with some of these more aggressive therapy plans. We do have a couple of people in our group, COPD Navigator on Facebook, who have used the vest. I don't know if anybody is going to tell you that they really like it, but I have had people tell me that they love it because it helps them move a lot of that stuff out. It helps remove some of the symptoms, the shortness of breath, the constant cough, and all that sort of thing. And it does allow them to live a more engaged life. So it's not necessarily something you do for fun, of course, but it's certainly something that can be a very effective part of your therapy plan. And lastly, we're going to point out we've got in a couple of weeks on March 5th, there is actually a what they call a town hall meeting. It's online. Bronchiectasis and non-tuberculosis mycobacteria. It's a deep dive into bronchiectasis and NTM, sponsored by the Bronchiectasis and NTM Initiative, which is operated in part by the COPD Foundation, featuring Dr. Tim Acasmet from the Mayo Clinic. It's going to be about an hour long. It's going to answer a lot more questions in a lot more depth than I can handle today. So I encourage anybody out there who is interested in bronchiectasis, interested in therapies, concerned that you might have this particular phenotype or this particular disease. Check this out. You can go to the SurveyMonkey link that you see on your screen right now. Go register for that, and then take a look and see what they have to offer. March 5th, 2 p.m. to 3 p.m. Eastern Time, the virtual town hall meeting with Dr. Tim McCasman. So with that, that is our topic of the day, bronchiectasis. Hopefully a little less of a phantom menace these days, as you get a little bit more information, a little bit more empowerment to take command of your own medical care. At this point, of course, the floor is yours. We open up, as we do every week, to any questions you might have. Haven't really seen a whole lot come in yet. Do want to say hello to Charles, Susan, Margaret, Ginny, Brad, A couple other people who grabbed the wrong mouse there. A couple other people. Robin came in earlier today. Want to also send a shout out to longtime navigator and friend of the group, Bonnie, still recovering from her lung transplant. I understand she is well on the road to recovery. Still having a rough go of it, of course. You know, anytime you go digging around in here, it's not something you usually jump up from the next day. But she is doing better and doing better every day, and we hope to see her back on Navigator soon. So, again, any of the questions that you might have don't necessarily need to be related to bronchiectasis. We can take medication questions, pulmonary rehab questions, harmonicas for health questions. We've got a lot of different things we can talk about, so if anything is on your mind, please feel free to throw that out there. We'll leave it open for some questions for a few more minutes here. Find out what is on your mind. We did in our group. If you're new to the show, if you're not an official group member, I invite you to come join us at copdnavigator.com or facebook.com/copd/groups/copd navigator. Come join our group. We've got a fantastic community full of people with experiences throughout all kinds of all forms of COPD, including some who have been diagnosed with bronchiectasis. Some post-lung transplant, some waiting for a lung transplant. We've got a lot of different people who are willing to share their wisdom and their experience with us, and we're very fortunate to have that around. So please come join us, whether you're living with COPD yourself, you're a caregiver, you are a family member, you're a respiratory therapist, nurse, physician. We welcome anybody with an interest in COPD and the COPD community. Well, not seeing a lot of questions come by today, so that's cool. We'll probably start wrapping things up in a few minutes here. I do want to wish everybody a happy Friday, of course. We've got some new topics lined up. We've got a couple more to get through February. I'm trying to remember what our topic is for next week exactly. But we do these talks every Friday at noon Eastern Time. Schedule permitting, of course, every now and then. I do have some other responsibilities I have to commit to, but try to do these every Friday at noon Eastern Time. Next week is what's the plan? Next week we talk about developing a management plan or an action plan, something that everybody should have in their arsenal. Here in Kalamazoo, we do try to we've kind of based on some other action plans that we've seen through the years. We've kind of come up with our own action plan where we talk about what we're doing for people when they have their normal breathing days, when days are a little bit worse, and then when you have kind of your red alert days. And this is something that I feel strongly that everybody should have. The COPD Foundation recommends everybody have, and is a very helpful tool for making sure that we can guide you through the process here. COPD is not a simple disease. There's a lot of complex stuff. There's a lot of different inhalers in play. There's a lot of unique devices that we have to teach you how to use. And sometimes everybody needs a little bit of assistance, making sure that they understand the plan so that we can all be on the same page and make sure that you're getting the best care that you deserve. Carol, thanks for joining us today, new to the group. Appreciate you stopping by and taking some time to hang out with us on a Friday afternoon. Hopefully we'll see you around the group some more. We'll see you next week as we talk about these COPD action plans. Hey, just got a like from Bonnie. Speak of the devil. Hopefully Bonnie is doing a little bit better today, better every day, hopefully, and moving forward to back on the road to wellness, as they say. In March, we've got a couple other exciting events coming up in 2 weeks. We have one program that I'm really looking forward to called Do Not Do. I came across a expert panel review last week that talked about some of the things that are most overused in the world of COPD. So we're going to be taking a look at that. We're going to be also in March. We're going to be taking a look at busting some myths involved in COPD. We're going to be taking a look at non-invasive ventilation. You know, again, medications and stuff are a very frontline therapy in the world of COPD, but there's a lot of other stuff that we need to do. We don't always need to be 100% reliant on meds to get stuff by. There's a lot of other stuff that we can do to support your respiratory drive and all that kind of stuff. We're going to have a redo or a modernization, take two of a talk we did about 6 months ago, I think it was, called The Talk. We're going to talk about some difficult conversations that a lot of people have, talking about palliative care and hospice and that sort of thing. And then we're going to end up the month by going under the knife and talking about some of the surgical and non-surgical bronchoscopic interventions that we can do to help manage this disease. So that's what's coming up on tap in March. It's going to be an exciting time. I think I have finally figured out all the technology. I was just looking, as a matter of fact, yesterday, I believe it was in my Facebook, they have the on this day in review kind of thing. We've been doing these talks for a little over a year now. I must have missed it last week, but yesterday was on this day was the second talk I did about oxygen, which will probably be coming up again in April. But we've been doing these talks for a year, and we've recently upgraded some of the tech here. It's a little less grainy, a little bit easier to hear, hopefully, than it used to be. And I think we finally even got some of the power issues and camera issues and some of that stuff resolved. I've been able to upgrade the graphics a little bit, and we've come a long way in the last year. So let me take a moment and thank everybody who has been a part of Navigator, certainly everybody who has joined us over the last year, and everybody who's been here even longer than that, making the group thrive as much as it has. I very much appreciate your assistance in building the community and for welcoming me in and letting me learn from you and share some of the stuff that I've picked up along the way from the clinical standpoint. So with that, thank you, Bill. Thank you, Jim and Mary. Thank you, Linda, for stopping by. We'll go ahead and wrap that up for today. Again, hope to see everybody next week here at noon Eastern Time. We're going to talk about COPD action plans. Until then, make sure that you are taking care of yourself. Make sure you're taking care of each other. And have a great weekend, everybody.